All right, let's do a quick overview of head injury. So head injury includes any traumatic damage to the head. It can be an open traumatic brain injury, and you'll hear us, call traumatic brain injuries TBIs. So if you hear that term, know we're just talking about a head injury. So open is when there's a fracture or penetration of the skull. Closed is when it's related to blunt trauma. It's typically more serious because there's a greater increase in intracranial pressure when we have that closed injury. Increased intracranial pressure is always going to be that main concern after a head injury. It's related to swelling, hemorrhage, and hydrocephalus. It can cause decreased cerebral perfusion, which can cause permanent disability. The forces of impact influence the type of traumatic brain injury. So you will see acceleration injuries, and those are caused by the head being in motion, and then deceleration injury is when that head stops suddenly. And so, that's where sometimes a lot of our education, when people are have like risky hobbies, whether it be riding a skateboard, a bicycle, a motorcycle, a scooter around campus, wearing helmets can help prevent these acceleration, deceleration types of head injury. This goes some warning signs. The first time we see changes in our level of consciousness. So if they have increased drowsiness, confusion, or we have difficult to arouse the patient, that is concerning. Of course, if we see any seizures, any bleeding or drainage from the nose or ears, changes with pupils, so they're slow, unequal. If they complain of blurred vision, double vision, and of course, if we have any loss of sensation to extremity, slurred speech, or projectile vomiting. We mentioned increased intracranial pressure. This is one of the most important things that we want to identify early on and resolve. So with increased intracranial pressure, probably the first thing you're going to see is that change in level of responsiveness. Second, look for changes in vital signs, such as, you'll hear it called Cushing's triad. This will be a widened pulse pressure, and that's an increased difference between the systolic and diastolic blood pressure, a low heart rate, and irregular respirations. You might see a rise in temperature, complaints of headache, that projectile vomiting, pupillary changes. All of those can be signs of increased intracranial pressure. Immediately report this to the healthcare provider. We may need to get a CT scan, MRI. If we notice that we have an epidural or subdural hematoma and that we get like a collection of bleeding, they may require surgery. You might also see EEG for these patients to identify any type of seizure activity. So again, we want to watch with these patients and make sure that they've do our ABCs, adequate ventilation and airway. So look for any signs of hypoxia or high CO2, hypercapnia. Position these patients, semi-prone or lateral to prevent aspiration. They still need to be turned side to side to prevent, atelectasis or pneumonia development. Keep that out of bed elevated 30 to 45 degrees. That will help actually aid in venous return and can help decrease that cerebral volume. So that can actually that position alone can help, control our increased intracranial pressure. These patients need frequent vitals and neuroassessment at least every 1 to 2 hours. Watch that Glasgow Coma Scale rating, and we want to notify healthcare provider immediately with any sign of deterioration. There are some things when we're talking about intracranial pressure that can actually increase intracranial pressure. So we want to avoid these types of interventions. So, you know, we do need to reposition them as part of our avoiding pressure ulcers, but, you know, don't overposition these patients with extra, you know, like caregiving. Make sure you don't have extreme hip flexion. That if you have extreme hip flexion when you're positioning these patients, that can help decrease that venous return. Endotracheal suctioning, compression of the jugular veins, coughing, vomiting, any type of straining. So we'd want to discourage any Valsalva maneuver. Anything that might increase interthoracic pressure can cause a rise in intracranial pressure for these patients. If we have somebody that does have, you know, they're not stable with their intracranial pressure, so we identified it, we can do assessment of it, and so these patients can actually have intracranial pressure monitoring systems placed. And this is done by inserting a catheter into the lateral ventricle, a sensor is placed on the dura, or they might have a screw, and then we can look for, actually monitor numerically that intracranial pressure. This is a head injured patient on a ventilator. And then this right here with the red arrow is an example of where you might have a burr hole with an intracranial pressure monitor. And once you have that, anytime you have a rise over 20 milligrams of mercury, you want to get that reported stat. There are medications that we see for increased intracranial pressure. These are those osmotic diuretics such as mannitol. We will see steroids used for head injuries, so Decadron, methylprednisolone, and then you might also see the use of barbiturates used with these patients as well. Patients with severe head injuries can end up on a ventilator. If you recall back to the previous picture that I had up there, they'll have a Foley catheter inserted. You'll need to closely watch I&O, especially with the use of osmotic diuretics. These patients can be very, very restless and agitated, and typically restraining them only increases that restlessness. We want to try to avoid the use of narcotics because that's actually going to mask their responsiveness. Sometimes you'll see that patients will have hyperventilation ordered when they're on a ventilator. This can lead to respiratory alkalosis, and that causes cerebral vasoconstriction and actually decreases cerebral blood flow and therefore can decrease the ICP. So that's for very severe injuries when they're on a ventilator. We can do hyperventilation to try to bring down that ICP. These patients will need seizure precautions. They have all the risk of immobility, so we need to be turning, positioning, doing assessments, and they can end up with very long recovery periods. So typically they're stabilized in an acute hospital setting. They may be in an ICU for a few weeks, then they get moved to a step-down unit. If they're stable, their time on a step-down unit may actually not be too long. This is typically a time where they'll be doing PT, OT, speech evaluations and working with case managers to get transferred to a rehabilitation unit. And then they'll be transferred to a rehabilitation unit to try to relearn how to do all their activities of daily living or live with any permanent impairment or disability that they may have.